The Radiology Review is pleased to offer the Board Exam Study Guide, episodes 1 through 101, available for purchase as a book on Amazon or in Kindle version. Welcome to the Radiology Review podcast, your on-the-go source for radiology education with your host, Dr. Matt Covington, a board-certified radiologist. Please follow the podcast on Twitter at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website theradiologyreview.com.
Welcome back to the Radiology Review podcast. This is episode 2 of my review of nuclear medicine bone scans. I hope the last episode on nuclear medicine bone scans was helpful for you, and this episode will continue to help you prepare for your upcoming board exams or other radiology education needs. Reminder that there is a discount code section on my website where you can frequently find discount codes for things like board preparation Q banks. So to save a few dollars, check that out at theradiologyreview.com to find currently available discount codes. Additionally, follow at RadRev Podcast on Twitter or Instagram, where I, on most days, am posting educational facts. And finally, a reminder that once all episodes on nuclear medicine bone scans have been posted, I will make a free downloadable study guide on this topic available at theradiologyreview.com. I anticipate that this will be a 3-part series, and the third part will focus a lot on 3-phase bone scans, which is a highly tested concept and a point of confusion for many radiology and nuclear medicine trainees. So make sure and check that out. I will try to release that within coming weeks. Without further ado, let's get into the questions and answers for this episode. First, I need to provide a clarification on a question from the first episode regarding heterotopic ossification. I previously said that mature heterotopic ossification has no bone scan uptake, and this was too simplistic of an explanation. Mature heterotopic ossification is best evaluated by a 3-phase bone scan serially to assess for a decreasing amount of blood flow and blood pool activity and delayed uptake that may either decline to a steady low level or completely resolve. Mature heterotopic ossification can have a persistent low-level amount of delayed uptake or resolved delayed uptake, as I had previously said, but importantly has resolution of hyperemia, which is manifest by a decreased or resolved amount of blood flow and blood pool activity compared to baseline. Additionally, I want to point out that a 3-phase bone scan is often able to detect heterotopic ossification earlier than radiographs, so this can be helpful for the initial diagnosis of heterotopic ossification. Again, I will expand our discussion of a 3-phase bone scan on the next episode, which will be the final episode of this 3-part series on nuclear medicine bone scans. Next, what is flare phenomenon on a bone scan? Flare phenomenon occurs when a patient with osseous metastases starts therapy, the metastases reduce or resolve, the bone starts healing where the metastasis was, and increased uptake is seen on the first post-therapy bone scan. Well, on imaging, this can look like the bone metastases are actually getting worse due to increased activity, or even new areas may be identified wherein bone at tiny, previously undetected metastases is now healing. All new and increasing uptake is actually due to a healing response from therapy rather than worsening metastases. That leads us to the next question. How does one confirm whether increasing uptake on the first post-therapy bone scan is due to flare phenomenon or worsening disease? The key to answer this question is that one must get additional follow-up imaging after the first post-therapy scan to confirm flare phenomenon versus worsening metastatic disease. At follow-up 2, perhaps 2 to 3 months after the initial follow-up, If uptake is now decreasing, this confirms a flare phenomenon at the first post-therapy time point. However, if uptake continues to worsen, this is most consistent with disease progression. So remember, on the first post-therapy scan, new or increasing areas of uptake on a bone scan can be either progression or a flare response. And what you need to do is then wait for the next bone scan to see whether things are getting better or worse. Next question. What is the classic imaging appearance of a sacral insufficiency fracture on a bone scan? I bet many of you were expecting this question to be on episode 1 of Nuclear Medicine Bone Scans because it is a very commonly taught and tested concept. A sacral insufficiency fracture typically presents with an H-shaped area of uptake over the sacrum comprising 2 more laterally positioned vertical fractures through the sacrum, which are connected centrally by a horizontal fracture. And this has been termed the Honda sign, like the H from Honda, the vehicle. Classic history would be an elderly female with osteoporosis presenting with new sacral region pain. Next, if only one hot bone lesion is seen on a bone scan, what is the approximate % likelihood that the solitary site of uptake is due to osseous metastatic disease? This is a question that is truly a classic and is often taught. The answer is that a solitary focus of uptake on a bone scan has an approximate 20% likelihood of being secondary to an osseous metastasis. An exception to this rule is the solitary sternal uptake in the setting of breast cancer, in which the likelihood of malignancy may actually be greater than 50%. Some reports do exist that show a solitary rib lesion in a person with malignancy may have up to a 40% chance of being malignant, but others show a lower rate of about 10%. Ultimately, I do not really like this question, as there are many factors at play, including any history of recent trauma or poor conditioning that would increase risk of fracture in clinical practice, such as a patient who has frequent falls. But for board exams, I would generally remember a 20% likelihood of malignancy, with the exceptions I've noted, and the most important of those exceptions would be the solitary sternal lesion in the setting of breast cancer, in which the likelihood of malignancy is at least and possibly greater than 50%, because breast cancer does have a propensity to metastasize specifically to the sternum. Next, if you see scattered areas of increased and decreased uptake throughout the osseous structures, as well as a hot or partially hot spleen, what underlying condition should you think of first? The answer I'm looking for here is sickle cell disease, which often presents with variable bone uptake due to various ages of bone infarcts. Remember from the last episode that early bone infarcts can have peripheral uptake and chronic bone infarcts have decreased or absent uptake, and additional splenic uptake, which in the setting of sickle cell disease is caused by splenic autoinfarction. Note that sickle cell disease can also be associated with increased renal uptake. Next, technetium 99M elution with aluminum breakthrough can cause what imaging manifestation on a bone scan? This is really a must-know fact for the core exam and any nuclear medicine board exam. The answer is that if you have aluminum breakthrough within the technetium 99M elution, you can end up with hepatic uptake on a bone scan. And this is a potential non-metastatic cause of hepatic uptake on a bone scan. Remember this must-know fact of aluminum breakthrough causing hepatic uptake on a bone scan. Next, what are classic potential causes of poor technetium-99m and MDP binding during radiopharmaceutical preparation. Poor binding of technetium-99m to MDP during radiopharmaceutical preparation can result from air in the vial or syringe during preparation that can cause poor binding, or else not having enough stannous ion in the preparation to reduce the technetium-99m, which is a necessary step for technetium-99m to bind with MDP. This results in imaging contamination from free technetium-99m on the bone scan, which results in things like abnormal salivary gland, thyroid, and gastric uptake, as we have already discussed on the first episode. And for those listeners who have listened to many of my episodes, I hope you are getting the correct sense that free technetium is a commonly tested concept on radiology and nuclear medicine board exams, because it is. Next, beyond metastatic disease, what are 3 classic non-malignant causes of abnormal renal uptake on a bone scan? Non-malignant causes of renal uptake on a bone scan include renal insult from nephropathy, which can result from chemotherapy, and this can be seen on the post-treatment scans as new diffuse renal uptake. Or consider other renal insults as well as hemochromatosis and urinary obstruction. With urinary obstruction, I would expect to see hydronephrosis, and if the hydronephrosis is severe, you might also see some delayed clearance of radiotracer from the kidneys and therefore slightly increased renal activity. Next, true or false? A primary breast cancer can show abnormal breast uptake on a bone scan. The answer here is true. Soft tissue uptake in the breast on a bone scan can be a manifestation of breast cancer. This is not necessarily unique to MDP. Remember also the association of breast cancer and technetium sestamibi. In fact, I would predict that sestamibi uptake would be the more likely to be tested. That being said, areas of non-osseous uptake on bone scans, such as breast tissue in the setting of breast cancer, are relatively commonly tested. Next, true or false? Technetium-99m MDP uptake is a function of blood flow and osteoblastic activity, with binding of MDP to hydroxyapatite on the mineralizing bone surface. Hopefully this is an easy answer for most of you. The answer is true. And for gamesmanship, if you have a question that is as detailed here, where I say technetium MDP is an uptake of blood flow and osteoblastic activity with binding of MDP to hydroxyapatite on the mineralizing bone surface, that is pretty detailed. That is likely to be a true question, or in a multiple choice series where you have maybe 4 or 5 options. If you don't know what the answer is, sometimes selecting the most detailed question stem will lead you in the right direction, because test writers often don't want to include needless detail on a false question stem. Next, how long after radiotracer injection is imaging for a single phase bone scan typically performed? The answer I am looking for here is 2 to 4 hours. If you only can remember one of these, I personally would remember 4 hours. After radiotracer injection, you usually wait about 2 to 4 hours until you start imaging on a single phase bone scan. If a patient has renal failure, however, one could image after 4 hours, and the rationale would be that imaging even later would allow improved time for renal excretion, which clears tracer from the soft tissues and therefore would theoretically improve signal to noise. Next, what is the classic imaging pattern of rib fractures on a bone scan? This is another highly tested concept. Rib fractures on a bone scan classically appear as focal areas of uptake in multiple contiguous ribs in a linear pattern reflecting contiguous rib fractures at and surrounding the site of impact to the ribs, often with similar uptake at all sites, as all are typically the same age if it is from the same traumatic event. Next, what is the classic imaging pattern of rib metastases on a bone scan? Rib metastases on a bone scan would show, rather than linear contiguous areas of uptake as in trauma and rib fractures, rather scattered areas of rib uptake, often with varying intensities of uptake due to different ages of the metastases, and these would be more diffuse than the pattern noted with rib fractures, especially if uptake is seen spreading through the marrow space of a rib rather than a focal single point. You should think of bone metastases. If you see uptake that follows a portion of the length or curvature of the rib, this again is highly suspicious for metastatic rib involvement. If you see scattered areas of rib uptake combined with suspicious bone uptake elsewhere, suspicion for rib metastases is further increased. Also, remember that pathologic fractures, where metastatic bone that is weakened undergoes a so-called pathologic fracture from minor trauma or minor load bearing, cannot be differentiated on a bone scan, but may be suspected, particularly if a coexisting lytic or soft tissue lesion is seen on corresponding CT or MRI imaging at the site of fracture. Next, what is the typical pattern for osteoporotic compression fractures of the spine on a bone scan? The answer I am looking for is that multi-level, linear, abnormal areas of uptake of different intensities are classic for osteoporotic compression fractures on a bone scan. Note that a single vertebral body with linear type uptake is also consistent with a compression fracture, but whether this is pathologic or due to osteoporosis would be uncertain based off a bone scan alone. But if you see multiple areas of linear type uptake, especially if they are of different intensities, that is most consistent with an osteoporotic compression fracture process. Now, if you are concerned that there may actually be a pathologic fracture, CT or MRI can be very helpful to evaluate for any underlying lesion to suggest a pathologic compression fracture. I would remember for board exams that multi-level linear areas of uptake of varying intensity are the typical pattern for multi-level osteoporotic compression fractures. These would be expected to show decreased uptake on follow-up bone scans due to healing and reduced osteoblastic activity over time. Next, if you are called by the technologist to check a bone scan prior to the patient leaving and uptake over the pelvis is seen that is indeterminate for metastases versus urine contamination, what is the next best step? The answer I'm looking for is that you should remove potentially contaminated clothing, clean the skin, replace the gown with a clean gown, and re-image the pelvis. And in this setting, if the activity goes away, then it is urine contamination. Note also that a tail-on detector view can also help differentiate uptake that is external to the pelvis from true bone metastases. Next, if you see focal abnormal myocardial uptake on a bone scan, what are the primary diagnostic considerations for board exams? Focal abnormal myocardial uptake on a bone scan on a board exam would cause me to first consider myocardial infarction with myocardial necrosis or a ventricular aneurysm as a possible consideration. Abnormal myocardial uptake on a bone scan has also been reported with unstable angina, so appropriate cardiac workup would be indicated in any event of abnormal myocardial uptake on a bone scan. Next, if you see diffuse abnormal myocardial region uptake on a bone scan, rather than focal uptake, the uptake is now diffuse, what are the primary diagnostic considerations for board exams? Diffuse abnormal myocardial uptake on a bone scan should cause you to think of diffuse pathologies of the heart to include things like cardiac amyloidosis, pericarditis, chemotherapy-induced cardiotoxicity, and cardiomyopathies such as alcoholic cardiomyopathy. And that leads us to the last and final question for this episode. If you see diffuse increased lower level activity throughout the abdomen, what should you first consider for board exams? The answer I'm looking for here is ascites. The same principle holds true for the thorax, wherein low-level diffuse symmetric or asymmetric uptake projecting over portions of the lungs or only a hemithorax can be a manifestation of pleural effusion. One should always evaluate for causes of malignant ascites or pleural effusion if not already known. Soft tissue extraosseous uptake can result from abnormal blood flow, abnormal capillary permeability, or extensive calcifications in the tissues to include things like calcified femoral or other major calcified arteries. Hypercalcemia and other calcium depositing diseases can also cause abnormal uptake on a bone scan. Other considerations for soft tissue extraosseous uptake, as we have already discussed, include malignancies, whenever uptake is focal and abnormal, such as in the breast with potential breast cancer. In terms of evaluating for ascites or a pleural effusion or a pericardial effusion, look for what is typically a lower level of diffuse uptake projecting over the applicable area, and sometimes you will only perceive the abnormality if you look for it. So if you are getting tested on a bone scan, and you simply are not seeing anything abnormal in the bone, start looking around in the soft tissues. First, ask yourself, is there absent renal and soft tissue uptake? If so, they are likely testing you on a super scan, which we described in episode 1. Look over the hemithorax for any evidence of pleural effusion. Look over the breast and heart for abnormal uptake there. And look over the abdomen to see if there is diffuse increased uptake to suggest ascites. Finally, I would consider looking at the liver to see if they are testing you on aluminum breakthrough in the technetium elution. And finally, look for other things such as increased renal uptake or the spectrum of sickle cell disease, which we have described. Although sickle cell would also be expected to have coexisting bone abnormalities as well. That sums up a lot of information. I hope this is helpful for many of you. I will have a final episode on nuclear medicine bone scans, and the primary focus of that episode will be 3-phase bone scans. And I would make sure and check that out because 3-phase bone scans are complicated and highly tested. I will additionally cover some of the highest yield topics on bone scans that I can think of, which I have not yet addressed in the first 2 episodes, and there certainly are some goodies that still deserve being mentioned and understood. So do not miss episode 3, and with that, we will close. Keep up the good work and study hard. Remember, you have to study really hard to succeed on radiology board exams. So prepare to succeed. I will catch you on the next episode. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.
What's better than listening to the Radiology Review?
Nothing.
Well, true. But you could buy our book, The Board Exam Study Guide, Episodes 1 through 101, available for purchase as a book on Amazon or in Kindle version.